I'm also involved in clinical research with Cochrane, the American Academy of Optometry, and a few other myopia research projects going on in Africa at the moment. Also with the British Contact Lens Association uh, on corneal techniques for managing presbyopia. So today, again, we can't talk about orthokeratology for myopia control without talking about the condition itself. All optometrists know what myopia is. We know that it is when you have parallel rays that focus before the rest when accommodation is relaxed. And this would lead to blur distant vision. The International Myopia Institute defines myopia as a spherical equivalent refraction of less than minus 0.5 diopters, and this is with cycloplegia because accommodation has to be relaxed, of course. The degree of myopia, there are different classifications. Some researchers or some groups will classify it as low, moderate, and high. But what the IMI recommends is low myopia. That's myopia that's minus 0.5 to minus 6 diopters. And high myopia is myopia minus 6 diopters beyond. Pathological myopia we would define as axial length greater than 26 millimeters with associated posterior segment pathologies. Prevalence of myopia varies in different parts of the world. We'll focus on what's more important to us in Africa. A recent meta-analysis by Obinwanne C looked at the prevalence of myopia in school-age children across Africa and found that it was about 4.7%. A recent study that looked at the prevalence in Abuja, I happen to practice in Abuja, so and also because I'm involved in myopia research, so I have to quote what's prevalent in Abuja. It's about 2.7%, but that varies depending on the geographical location that you're looking at. Now, why do we even bother about myopia control? Why is it such a big thing? Why is there so much interest or products or research going into myopia and myopia management? It's because of the projection from the Brian Holding paper from year 2000 that shook the world, 2016 that shook the world. Now, that paper projected by the year 2050 half the world's population, about 49.5% to be exact, will become myopic. And in Africa, studies have projected that the prevalence will rise from 4.7% to about 17% by the year 2050 in school-age children. Now, if you put this into context, half of the world's population being short-sighted, it makes you wonder what kind of complications we will see by then and what significant impact to the way we practice. Now, aside from that staggering statistic I just quoted, here's what's more troubling. Now, this is a study that was done, I think this was last year or 2 years ago. I was part of the researchers that did this study, and we looked at the trends of myopia management across Africa. And I mean, you would think that with all the news and the rave about myopia management, we will practice differently. So this is a nice excerpt, a table from our study, and I just highlighted a part of it here. You see that over 50%, over half of the people of the eye care practitioners we surveyed still believe that single vision spectacles give some form of myopia management. I mean, for all the countries, you see about 64.3%. In Nigeria, we sort of did fairly better. About 59% of us thought we could use single vision for myopia management versus 76%, almost 77% in Ghana. What this means is we're not doing enough in teaching about myopia management, practicing myopia management, and educating people about myopia management. That's why we bother. Another reason we bother is the complications we see. One of the most feared complications of myopia is myopic macular degeneration. This tends to affect Asians more, but like I said, I do practice myopia control on a day-to-day basis, twice a week actually, and I tend to see this in children as well. So there's not much research that goes into pathologic myopia in children, specifically African children. So that's something we're trying to change. But we know that it does exist. And sometimes we look at the fundus of kids with high myopia, say -8, -9, -10. I've seen as high as 34. And you would often see that diffuse tessellation. That tessellation going across the macula alone is enough to classify that patient as having category 1 myopic maculopathy. Now, if that tessellation goes with choroidal atrophy or chorioretinal atrophy, that's category 2. We consider category 2 being clinically significant, and it goes all the way down to having posterior staphyloma. You can see the images on the screen. Now, this was taken from the Meta-PM study that did a photographic classification of myopia of myopic maculopathy. Another feared complication is cataracts. We all know about cataracts. We know the burden that cataract contributes to blindness worldwide. I just moved this out of the way. I don't know if it's showing on your screen as well, but on the screen, we have cortical cataracts, nuclear and posterior subcapsular cataracts. And we tend to see, so what you should pay attention to is this red line here with the error bars in it across the graphs. So basically, this study was a meta-analysis. They took pooled results from different studies that had looked at risk factors, the odds ratio of developing cataracts of different forms. Overall, you're likely to have a posterior subcapsular cataract if you have high myopia, and you're likely to have nuclear cataracts if you have high myopia. Obviously, I don't need to talk much about the glaucoma part of things. It's obvious because the axial length would stretch and increase, and that increase in axial length will lead to stretching of the posterior segment tissues, the choroid, the retina, and that can lead to a retinal tear, retinal detachment. There are different options for managing myopia. We have spectacle options, we have contact lens options, we have low-dose atropine, there's red low light therapy that's being researched for the same purpose. There are different options out there, but today we're focusing obviously on the contact lens option and specifically orthokeratology. Now, orthokeratology is a non-surgical reversible procedure where we use dark permeable lenses to gently reshape the corneal curvature. Now, the pictures you're going to be seeing here are either pictures from my patients or topography from my patients or topography or pictures from the BioLens laboratories. Now, orthokeratology has certain indications. Some of them I would speak about by the rules, and some of them I would speak from experience. Generally, the indications will be obviously somebody who has myopia, but keep in mind, orthokeratology can also be done for hyperopia and presbyopia, but today we're focusing on myopia. Often a patient who maybe is experiencing contact lens discomfort, whether that may be due to dryness of the eyes, is a good candidate for orthokeratology. The patient who obviously wants to undergo myopia control, most times this will be children, but sometimes we also do myopia control for adults with progressive myopia as well, with orthokeratology lenses. Patients who are contraindicated for refractive surgery. However, keep in mind, contraindicated for refractive surgery but do not have keratoconus, because we do not want to be reshaping the cornea of reshaping an irregular cornea, because we will likely induce progression in the keratoconus or more corneal ectasia. Patients who are active in sports, footballers, swimmers, bikers, who may be in dusty terrain or be in the water but still want to wear contact lenses, orthokeratology is great because then you have clear vision without the aid of anything on the eyes. Patients or individuals who want that freedom from glasses or contact lenses, this may be for vocational purposes, or they're just fed up with wearing glasses. Well, the age limit theoretically is 6 to 66. I mean, yeah, the youngest I've done is 6. I haven't done anybody up to 66. I think the oldest I've done is a 40-something-year-old, late 40s, but yeah. But yeah, I don't see any reason why somebody older than 66, so long as they meet the criteria for orthokeratology, will not be, we should not be fit with the lens or with the procedure. Typically, the FDA says a range of -5 to -6.5 as the limit for myopia, managing myopia with orthokeratology. Personally, my limit, what I have done, the highest I have done is -8.5 with astigmatism of -2.5. That's the highest I have done. But usually when you're starting off with orthokeratology, you want to pick a power that's within this range so that you build your confidence, you build your clinical experience as you go on. So yes, these are guidelines, but truthfully in healthcare, it's good to follow principles. But when you've gained the confidence and the clinical experience, as a pace setter, you may also set your own rules, so long as you're not endangering the patient. Typically, astigmatism less than 1.5 diopters with the rule, and 0.75 diopters against the rule. But we now have toric orthokeratology lenses, which I'll talk about later as we go on. So sometimes we don't necessarily follow that astigmatism rule. However, the reason that rule is in place is you need to keep in mind that the predictability of orthokeratology reduces with such high astigmatism, and the lens fit may be rocky. It may not be well centered, it may not be very stable. So that's why we have that rule in place, because RGP lenses on toric corneas tend not to center well except you do a back surface toricity to the lens. Usually, now this is a rule of thumb, we do not want the cylinder to be half, more than half rather, of the sphere. Say for example, I have a patient who is a -2 with a -6 cylinder, for example. I will be very careful doing orthokeratology for that patient. But if I reverse that and I have a patient who is a -6 with a -2 cylinder, I will try orthokeratology for the person. Now, some contraindications for orthokeratology will be severe dry eye disease, obviously. Patients who have very high corneal astigmatism or irregular astigmatism, or limbus to limbus astigmatism. Now, there is apical astigmatism when you do your topography and you have the astigmatism falling within the 3 to 5 mm zone of the your topography. Now, when it extends to the periphery, usually they're not such great candidates for orthokeratology. It's not like you can't try orthokeratology, it's just that the centration of the lens may be an issue, chances of success or predictability may be an issue, and the lens may be rocky or uncomfortable. Patient might have difficult time sleeping, so we may not want to do orthokeratology for those patients. Again, when you're starting off at the beginning, I'd say pick your battles fine. So I would not start off with somebody who has a limbus to limbus astigmatism if I were fitting Ortho-K lenses for the first time. But as you get experience, I have fitted a couple, maybe 1 or 2 that were successful, but it was not like it was a one-time straight away fit, or that one lens and everything was perfect. Sometimes they require 2 or 3 fits. This is where working with a very good lab that has a very good return policy and warranty policy is important. Obviously, patients with keratoconus, we won't be fitting them orthokeratology lenses. Post-refractive surgery patients. Now, this is tricky. I have fit a couple of these, but mostly during my residency days. And when you fit patients who've undergone refractive surgery, you need to manage the expectation, because the cornea is already biomechanically weak, and there is a chance that Ortho-K may work, there's a chance that Ortho-K may not work. These patients also are quite apprehensive, because the reason they went for refractive surgery in the first place was so they don't wear glasses or contact lenses. So this may not be your ideal candidate to start with, but it can be done. But for beginners, I'd say just stay clear of them. Now, individuals who have very large pupil. Now, this is because the treatment zone for the orthokeratology has to fall within the pupil. If it falls outside the pupil, patients get a similar effect to when you do refractive surgery for a patient who has very large pupils. They experience glare and halos at night, higher order aberrations, sometimes night myopia. This may affect the quality of vision or reduce higher order aberrations. Patients who have low corneal eccentricity, simply because you need this parameter to actually fit an Ortho-K lens properly. If it's too low, if the eccentricity is too low, that means the rate of prolateness, or how the cornea flattens from the center to the periphery, is not close to normal. These patients tend not to fare well with orthokeratology. They tend to have an under-correction or under-treatment. Same thing for individuals with flat corneas. Now, this same principle applies to refractive surgery, especially for the flat cornea thing. For example, someone doing LASIK with a flat cornea may have something we call the buttonhole flap, or the flap just goes, the microkeratom just goes through the entire cornea, and you have to probably convert to an ablation procedure like PRK to address the refractive error of that patient. Patients who obviously have hygiene issues, you shouldn't even be prescribing contact lenses in the first place. And when the parents, if you're doing it for a child, that is, when the parent or the individual is not willing to show up for follow-up, or there is no parental assistance for the child who's undergoing orthokeratology. I will tell you one thing from experience: kids make very fantastic contact lens patients, whether it's orthokeratology or multifocal contact lenses and fitting for myopia management. The problem usually comes from the parents. They instill that fear into the child, but if you actually take time to teach the child, you actually get the best out of them. And there is a study, I think that was the Clay study, that looked at contact lens in youth and found out that teaching children would only take you about 15 minutes more compared to teaching an adult to fit in contact lenses. So for those who've worked with me, you know that it's something that we do regularly. Kids as young as 6, 7, 8 we fit them with contact lenses, and you will hardly see complications in this age group because they have parental supervision and they often listen to instructions. It's when individuals start getting older and they feel they know everything and they start causing problems for both themselves and the practitioners. So the child being a child is not a contraindication for orthokeratology. Now, back in the days, I remember even in university, when we were taught orthokeratology theoretically, I mean, I didn't get to see or practice orthokeratology until residency, and now that I'm in clinical practice, using it regularly. But before, back then, we were taught that what orthokeratology does is it bends the cornea. But actually, orthokeratology lenses does not actually make contact with the cornea in most areas when it fits properly. Now, I've put a cross-section of an image from one of my patients here from the software that I use in designing orthokeratology lenses, just to give you a cross-sectional view of what it's like. Now, the areas where you obviously don't see fluorescein, we would think that that means a touch. But what we know from research is the human eye cannot detect fluorescein when the thickness underneath the lens is lower than 25 microns. So if you put an algebra in an eye and you stain it with fluorescein, that you're seeing something that looks like a touch does not always mean that it is a touch. Usually, if the fluid reservoir or the fluorescein thickness underneath the lens is lower than 25 microns, the human eye would not see it. However, that does not mean that it's actually compressing the cornea or touching the lens. We'll get to how Ortho-K works later on. So we see here in this image that it looks like there is a touch. However, there is 13 microns of fluorescein underneath the central part of this lens. Now, around this, we see from the graph, it goes to about 120 microns in the return zone depth. We'll talk about the zones later, but I'm just trying to explain how orthokeratology works. The only place we expect an actual touch or compression on the cornea is close to the periphery, where you have the alignment zone, because this is what guides the centration of the orthokeratology lens. Morphologically, we come to this image here on the right. We see that the stroma thickness is actually the same, whether it's in the center or in the mid-periphery. What changes is the epithelial thickness. And what's actually happening is the orthokeratology lens induces a positive force in the center and a negative force in the mid-periphery, where you have the return zone depth. So this is where you have the return zone depth. This corresponds to where the return zone depth is, and this corresponds to where the return zone depth is. So the negative force pulls or causes fluid retention within the mid-periphery of the cornea, and in the central part of the cornea, the positive force reduces fluid within the epithelium. So that causes flattening of the epithelium in the center and thickening of the epithelium in the mid-periphery. This change in epithelial thickness is guided by the curvature of the lens, and that curvature of the lens and the eccentricity of the lens is designed based on the corneal topography and the refractive error of the individual, and that's how orthokeratology corrects myopia and does myopia control, which we'll talk about later on. Now, there are different paths to an orthokeratology lens. We have the central zone. You have to see, for example, this is well centered within the pupil. So this was, I think this was a 15-year-old kid we have done orthokeratology for. She's about -6 point something. She's been plano for, I think this image was from 2021, if I remember correctly, and this patient has not had any progression since then. Now, orthokeratology at the central zone of the lens, we call this the optic zone or the treatment zone. Now, around that, we have this very uniform area of fluorescein, which we call the return zone depth or the return zone. Now, this zone is what's responsible for myopia control. I'll explain that later. Next is the alignment zone, the part that actually makes the contact with the cornea. Now, this alignment zone here is responsible for the centration of the lens, and then we have the edge profile of the lens where you have the peripheral zone, which should be about 1 millimeter thick with fluorescein, and that allows for tear exchange or slight movement of the lens when the lens is on the eyes. As I said before, the optic zone contributes to the treatment zone. The base curve of the optic zone is designed based on the flat K reading and the amount of myopia you want to correct. I'll give an example. Say I have a patient who's a -4 myope, and that patient has a flat K reading of, say, 46 diopters. So my goal is to knock off 4 diopters of myopia. So what I want to do is take that cornea from a flat K of 46 diopters to a flat K of 42 diopters. So what's going to happen is I'm going to make the central zone or the optic zone of the lens have a base curve of 42 diopters, so that when it's fit on the eyes, it flattens the central cornea, flattens the epithelium to the amount of myopia that I want to correct. But we actually tend to overcorrect myopia a little bit when we do orthokeratology. We call that the Jensen factor. Now that varies depending on the lab that you're using. It could be 0.5 diopters to as high as 1 diopter. I tend to use 1 diopter. Even if the lab I'm working with is using 0.5 diopters, I will add the extra 0.25 diopters, or sometimes even 150 diopters, depending on what I'm trying to achieve. But the idea is to move that patient towards hyperopia, so that by the time they're taking off the lens in the morning, you probably have about a plus 0.5 to about plus 1 hyperopia. And by the middle of the day, they become plano. By the time it's going towards the minus side, it's already night time and it's time to sleep and put on the lenses again. So that slight overcorrection could do. We either call it the compression factor or the Jensen factor, depending on the lab that you're using or what term that you decide you want to use. Now, what you need to keep in mind is the higher the amount of myopia you want to correct, smaller the treatment zone will be. If you also want to do myopia management, we actually want the treatment zone to be a bit small, pretty close to the pupil, so that you have this return zone depth close to the pupil. I'll explain why later on. Now, the reverse zone or the return zone, this is the part that has the pooling of fluorescein around it. Now, keep in mind, we call this pattern the bullseye pattern. This is what you want to see, a uniform distribution of fluorescein, or a uniform distribution of what looks like a feathery touch at the center, pooling of fluorescein around that, and a light fit around the pooling, and then adequate about 1 millimeters edge clearance. Now, the reverse zone, which corresponds to this part on the corneal topography. Now, you would see from this that the blue area represents the cornea being flat or compressed, or the epithelium being compressed in that area. Now, in the mid-periphery here, where we had the pooling, as we saw before, we see that the cornea has become steeper there. Now, this induces myopic defocus, which will in turn correct the peripheral hyperopic defocus in the retina. That's the reason why we want it to be close to the pupil when we're doing it for myopia control, because when we fit orthokeratology for vision correction and we fit orthokeratology for myopia control, we tend to want to use smaller optic zones or smaller treatment zones for myopia control, just so we can get this return zone depth close to the pupil as much as possible, so we can get more myopic defocus to correct peripheral hyperopic defocus in the retina. This reverse zone is actually controlled by negative hydraulic force, like I explained before, which would cause increase in fluid in the mid-periphery of the corneal epithelium. The alignment zone controls the centration of the lens, as I talked about before. Now, this will be calculated based on the corneal eccentricity and how the lens drapes over the cornea nicely. The edge will be where you have the thin layer of fluorescein, about 1 millimeter, uniform around the lens, and that's what tells you there is some tear exchange going on. Now, this I think is what I would consider one of my most perfect fits, or maybe one of the most perfect pictures I've taken of my Ortho-K patients. It may not always look this perfect, but that does not mean that you have fit a bad lens. Now, there are certain things that would help you fit Ortho-K lenses properly, or what you consider good criteria for you to have successful Ortho-K outcome. First is the candidate you select. Like I said before, when you're starting out, select your battles. Don't start off with somebody who's a -10 or a -12. It's not like this may not be theoretically possible. I mean, there are some lens designs that actually take care of high myopia. However, you want to build confidence, and also you want the patients to have that belief in you. The truth is, you fit one Ortho-K patient, they will tell somebody else, and they bring in somebody else, and they bring in somebody else. It's good for you professionally, it's good for your bank account, and it's also good for your morale, and you're also helping the patient manage myopia at the end of the day. You want to select your candidates properly, so you want someone who's less than -5 diopters. You want somebody who has low astigmatism, less than 1.5 diopters. You want somebody who is motivated, who obviously would agree to show up for about 2-3 follow-ups within a month. You want to get as precise topography as possible, and you should obviously be trained and certified in doing orthokeratology. Most of the labs will not give you an Ortho-K lens unless you are trained and you pass that training before you would be able to fit orthokeratology lenses. Pre-orthokeratology, pre-Ortho-K topography is a must because it helps you determine what patient is a good candidate, what patient has, hoping the cornea is not too flat, eccentricity is above 0.35, the myopia is at the adequate range where you want it. You don't want it too low, you don't want it too high to start off with. Now, post-Ortho-K topography is important for evaluating the fit of the lens you have put in and also doing some troubleshooting. Now, what data do you require? You require your central K readings, so the K readings from your 3 millimeters. So some topographers will give you something called a simulated K reading in the 3 millimeter zone. Some will give you the central K readings, whatever your topographer calls it. We want the K readings from the central 3 millimeters of the cornea. We also want the eccentricity value of the cornea. Now, some topographers may call that shape factor, some may call that the Q value or the sphericity value. We want that both in the flat meridian and the steep meridian. You want to measure the corneal diameter. Some topographers will give you this value, usually to be called the white-to-white corneal diameter. You want to measure the pupil diameter. It's very important if you're doing Ortho-K for the press bio, and very important if you're doing it for myopia control. And you want to look at how much myopia are you trying to correct, because sometimes for press bio, for example, I've done monovision orthokeratology. Sometimes you might be doing orthokeratology for a very high myope, and you're just doing partial orthokeratology, which means the child may still need glasses for a lower amount. Say the child is -10, for example, and you do Ortho-K to knock off -6 or -7 or -8, and for the remaining 2 diopters, they may wear glasses. But research has shown that even partial orthokeratology still gives myopia control compared to not doing orthokeratology at all. I mean, there are still other options that you can use. You could use multifocal, center distance multifocal contact lenses, low dosage pain, and other options available at your disposal. Orthokeratology is not a must. We're just saying that you can actually do partial orthokeratology for myopia management for high myopes. So the first step would be to do a very good subjective refraction. You do not want to over minus. You do not want to under minus either. You want the accurate duochrome balanced subjective refraction. The next thing will be to capture a very good corneal topography, get all the parameters that we talked about before up to your pupil diameter as well. Now, your lens selection will be based on the K readings, the eccentricity value, and the amount of myopia that you intend to correct. So, for example, I talked about the compression factor where we tend to overcorrect a little bit just so we leave the patient slightly hyperopic when they wake up in the morning. Now, that you would need to add to your correction factor. So, the companies most times will do that for you, but it's rare these days not to have a company that does that for you. But if they don't, if you wanted to correct a -4 diopter myopia, for example, and you wanted to use a correction factor of 0.75 diopters, that means you'll be doing a correction of about -4.75 diopters. But for example, Paragon CRT will give you a slide ruler where you slide the K readings, you put your K readings, you have the amount of myopia you want to correct, and it will give you a suggestion of a lens to start with. Put that lens on the eyes, look at whether it fits properly, adjust the return zone depth as you would want to adjust. Most times when we are adjusting Ortho-K lenses, when we're doing troubleshooting, we do not touch the base curve of the central portion because touching the base curve of the central portion will alter the amount of myopia that you're correcting. You would either end up over-correcting or under-correcting. So we only touch the return zone depth, we touch the alignment curve, we may touch the peripheral angle as well, the lens peripheral angle, or the landing zone angle, but we tend not to touch the central base curve, except in some rare cases which we'll talk about later on. Some labs would have you design your lens by yourself using a customized software, which is what I do most of the times. Maybe because I tend to want to be in control of the situation, but it's also okay to send all your data to the lab and they will send you a lens that you will fit. You need to keep in mind that you may not always have first fit success. Some labs will promise up to 86% first fit success. Sometimes that's not really what happens, but you need to keep that in mind as a practitioner, and the patient has to be aware that orthokeratology is a process. Sometimes it's a journey. I mean, the minus 8.5 myop that I hit, which is the highest I've done, was a one-time thing. And meanwhile, I did do 2 or 3 lens exchanges for maybe 1 or 2 minus 4 myops. So it does not always mean that the first lens that you order, or the first lens that you design, or the first lens you select from a trial set, if you have one, will be the perfect fit. Sometimes these things vary. Now, the second step will be evaluating the fit. Put the lens on the eyes, you put fluorescein, and see that the lens shows that both eye pattern that I showed before. Then you teach the patient how to insert and remove, you teach them handling the lens, the hygiene protocols, blah, 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 and then you dispense the lens. You often want to see that patient first thing the next day after you dispense the lens. So usually they are my first consultation for the day between 8 to 9 a.m. Now, when you put the lens on the eyes, the first thing you want to see is how the lens moving. Is it stable? Is it well centered? The patient may be teary a bit, plus or minus. Some people may instill fluorescein for the lens. Some people may not. Depending on the patient and the age of the patient, I may do that just to get them comfortable initially. But Ortho-K lenses are surprisingly quite comfortable compared to other forms of contact lenses. When you have looked at the fit of the lens and all that, and you dispense, then the patient comes the next day, you want to look at the staining. Sometimes, especially for high myopes, we may find central punctate stains on the cornea. You want to repeat the subjective refraction, because by now you should expect that about 50 to 70% of the myopia should have been corrected. You want to check unaided visual acuity, and then you perform topography. You're going to repeat these steps in 1 week visit and in 1 month visit. Sometimes I have the patients come in for a 2-week visit, especially for the high myopes, because I'm monitoring the changes that they go on. Now, this is what you want to see when you place the lens on the eyes. Nice, well-centered treatment or optic zone, the reverse zone or the return zone, nice with pulling of fluorescein around that, a very well-centered alignment zone, and adequate edge clearance in the landing zone angle or the peripheral zone of the lens. You want the lens to be well-centered, like I said before. It should move a bit when the patient blinks, like I also mentioned before, and then the other parameters I already mentioned before. Here's what we want to look at first day post-fitting care, the topography. You want to see that the lens is well-centered. You have a treatment zone that's centered within the pupil, and you have a revert zone that is around that treatment zone to give you the myopia control effect that you're looking for. Sometimes, not everything will go as planned. You may put the lens on the eyes and the lens looks like it's riding high. Anywhere, so long as it's an RGP lens, whether it's an Ortho-K RGP or it's a corneal RGP, a high riding rigid lens is a flat lens. So what that means is the Ortho-K lens you have placed on the eyes is too flat. When you do the topography the next morning, you will see that the patient has what we call a smiley face topography. You have this return zone depth, which should have been a uniform thing around the cornea, centered around the cornea. You see that it's sort of an inferior stiffening that you have, which if you're not well trained in interpreting topographies, you may think this maybe looks like a PMCD or an inferior cone for keratoconus. But when you see a smiley face rather, it indicates you have a flat Ortho-K or a high riding lens, and you it means you need to either increase the return zone depth, so you're increasing the sagittal height of the lens to make it sit well or fall back to the center of the cornea, or your alignment zone is too flat. You need to stiffen the base curves around the alignment zone. The beauty of Ortho-K lenses is you can customize a particular zone without affecting another zone, and you will get good topography. Same thing, you could have a frowny face when you have a lens that's too steep. You'll be riding low, and usually these patients tend to have an undercorrection of myopia when you take off the lens in the morning, and the vision would not be so clear. I mean, it will be better than their previous vision unaided, but it will not be that clear. It tends to complain of glare and halos, and sometimes even difficulty sleeping because the lens was probably moving to a point and then it got stuck at the inferior limbus, and they found it difficult to just keep the eyes closed and sleep. You could also have what we call a central island. Now, this is the case where you can actually flatten the central optic zone base curve by about 0.1 mm. This tends to happen when you are fit a lens where the return zone depth is too high, or you have, for some or whatever reason, fit a base curve at the center that's too steep. Now you would find something that looks like a perfect bullseye pattern almost, but you see the central island there. Usually just flattening the base curve by 0.1 mm usually will take care of that. I'm supposed to do a quiz here, so I am going to stop sharing my screen and try to see if I can pop that up. Just give me a minute. So this is the image for the quiz. So the question is what complication? So this is an Ortho-K patient I saw 2 weeks ago. So what complication is shown here in this image? I'll just leave it on for maybe a minute more and then take it off. So far I can see one vote. One person says frowny face. All right, so just put your answers on the poll. All right, so I'm ending the, I'm closing the image, and we'll look at the answers. Okay, so from the polls, I have 2 people saying frowny face, 2 people saying it's a central island. I think I did see some things on the chat section. Okay, so I'm seeing frowny face, somebody says smiley face, somebody says it's tipped, somebody says frowny face. Surprisingly, okay, yeah, somebody says central island. Well, let's go back to that image again. So this is actually a central island. So you see that there. So this patient, you see this uniform area that's flat here, except for this. This is the return zone that it's actually there, 360. But for the central zone, if you had a smiley face, for example, you would have this flat zone here, somewhere up there, and you would have the return zone depth down here, looking like it's smiling. But what you have here is actually a central island, not a smiley face. Thank you all for those who participated. And again, for those who had said smiley face, I do understand the confusion because it sort of looks like it's smiling from the right, but it's actually a central island. So we continue the presentation. I did talk about fitting toric orthokeratology lenses. I've done this a couple of times. They're a bit more expensive. They're a bit more tricky, but they're fun. maybe I'm just a freak and I like the challenge. But you see, this is an Ortho-K lens on a toric cornea. You see, it's not well centered. It's actually slightly high riding. You see this pulling of fluorescein here. This will often obviously result in a smiley face later on. Now, this is because the toricity of this cornea is greater than 1.5 diopters. What we often want to do is, aside from using the toricity as a yardstick, we want to look at the elevation of the cornea in opposing points in the 5 to 7 millimeters corneal topography zone. Now, if the elevation in opposing points is more than 40 microns, we will often advise to fit the toric Ortho-K. This is the same cornea, and you see that the Ortho-K lens is better centered. You have a better bullseye pattern. I mean, you can still see that the treatment zone looks oval, which still indicates that this cornea is toric. But the centration and the treatment effect you're going to get here will obviously be better than this. If you have questions, I mean, you can put them in the chat section. I'll be happy to answer them after the presentation is done. Now, we're coming close to the end of the presentation, but this will not be complete if we do not talk about efficacy of orthokeratology in managing myopia. There have been studies dating back to over 15, 20 years ago, talking or describing orthokeratology using reverse geometry lenses and things like that. Now we know that using a reverse geometry lens with a smaller optic zone will give better myopia control. However, how efficacious is orthokeratology for myopia management? Keeping in mind you're altering the refraction of the eyes. And something I should point out, because when you're using Ortho-K for myopia management, you're not going to be using the refraction as a method to judge whether the myopia has progressed or not, because you have already altered the refraction of the eye. So the patient will go from maybe a -4 to a +0.5 or a plano. What you're going to be using is the axial length as your method to judge whether myopia has progressed or not. Now, this is a study that was published quite recently in Contact Lens and Anterior Eye that looked at the efficacy and the predictability of orthokeratology lenses in a population that had used Ortho-K lenses for 18 years. And they found that it was very efficacious, gave myopia control as high as almost 80% in this study, and it was safe. There was only one person, not even a kid, one person who who had microbial keratitis from wearing orthokeratology lens, and that was promptly treated, and the prognosis was excellent. Surprisingly, or well, not surprisingly actually, the person was an adult, not a child. None of the children experienced microbial keratitis. The complication rates for microbial keratitis with orthokeratology lens is about 7.7 per 10,000 years of children or individuals who wear Ortho-K lenses. So they are pretty safe compared to your risk of having myopic maculopathy or having cataracts or having glaucoma or having retinal detachments from progressive myopia. So if you look at the risk from wearing Ortho-K lenses in kids versus the risk of developing complications, the benefits way, way, way outweigh the risk. And Ortho-K can be combined with other forms of myopia management. You could do Ortho-K with low-dose atropine. You could do Ortho-K with low-dose, low-light red light therapy. You could do Ortho-K and still use myopic bifocus lenses if there is some residual refractive error remaining to be corrected. So you could use Ortho-K with a couple of other interventions. So, I mean, the only thing limiting you is you getting trained and certified for Ortho-K, and you or maybe referring to somebody who does Ortho-K around you, and taking advantage of this opportunity to help your patients with myopia. Thank you guys for listening. That's my email. If you have any questions, I'll be happy to take any questions. Thank you so much.
Thank you, Dr. Chukwuemeka, for such an insightful presentation. And I'm sure a lot of us here have learned a lot. And I know I have already as well. That was very, very insightful. I have a lot of questions, but I'm pretty sure that the audience will have a lot more. And please feel free to keep posting your questions here, just so Dr. Chukwuemeka can answer them. So we have a few questions here for you, Dr. Chukwuemeka. Yes. So the first question is, does circadian rhythm affect Ortho-K lenses? That is, does the body react differently at sleep or lying down to sitting upright? I'm
So
sure.
if I get that correctly, the person is trying to ask if circadian eye movement affects Ortho-K.
Yes.
No, actually it doesn't. So I'd quote another study before I answer that question. So there's a study that looked at patients with nystagmus and how RGP lenses actually reduces nystagmus in patients. So we do not actually know the mechanism. We do not know why or how, but we know that in patients who have nystagmus, when you feed them with RGPs, it reduces the speed and the amplitude of the nystagmus. Ortho-K lenses are rigid lenses, number one. So if eye movement was an issue, it will reduce it. Secondly, you're wearing the lenses when you are asleep. The only time you will be bothered is during the rapid eye movement stage of sleep, where the eye is moving rapidly and you have an Ortho-K lens sitting there. Now, remember, the Ortho-K lens is actually not directly touching the cornea. You have a very thin layer of tear film underneath it. So it's usually not an issue. What we will consider an issue is somebody who has poor dexterity inserting the lens and removing the lens. That will be an issue. And for that, if there's a parent or a guardian who's there to help, I mean, that would not even be something that you should be bothered about. So I don't think that should be an issue.
All right. Thank you for the answer. I'm sure it's been quite understood. If not, you can still post more questions in the chat. So the last question is, what's the standard overall and pupil diameter for fitting Ortho-K lenses?
Sorry, say that again. What's the standard what?
What's the standard overall and pupil diameter for fitting Ortho-K lenses?
Okay, so if you're fitting, here's the thing. I do customized Ortho-K, so I do not subscribe to using a one-size-fits-all for everybody. If you're fitting with the Paragon CRT lens, it comes in a box with over 100 trial lenses, and they would come in a central or treatment zone of about 6 to 6.5 mm and a total diameter of about 10.4 millimeters. I fit Ortho-K lenses with diameter as high as 10.8, diameter as large as 11. It totally depends on the diameter of the patient's cornea. So do not subscribe to that one size fits all, because in the morning I might be fitting a -4 patient who has a corneal diameter of 11.5 mm. And in the evening, I might be fitting somebody who has a corneal diameter of 12 mm or 12.5 mm. So it varies. But if you're looking at the average, about 10.4 mm overall diameter, treatment zone of about 6.5, but that also can vary.
Thank you for that. The next question is, how long does it take to acquire lens certification for practicing orthokeratology?
So that's an interesting question. Training itself, I could teach somebody to fit Ortho-K lenses maybe in 2 hours, maybe. But here's what I often advise. Lenses, RGP lenses, before diving into Ortho-K. The reason I say that is because you're going to need all those principles from RGP fitting, soft contact lens fitting, understanding those basics before you start to fit Ortho-K lenses. Certification of the training itself, usually an hour or two, and then by the next day, we should be able to send you a certificate to fit it. But I would advise you have experience or some training in fitting RGP lenses first before you start doing Ortho-K. I often would tell my interns that Ortho-K is like the meeting point between contact lenses and refractive surgery, because we apply similar principles to refractive surgery, to orthokeratology. The only thing is it's reversible, it's temporary, and you're doing it with a contact lens. But the principles are quite similar in terms of design. And when you actually do topography for a well-fit Ortho-K lens, Ortho-K cornea, and you do topography for a cornea who's had LASIK for myopia or PRK for myopia, they will look quite similar because you've done the same thing, flattening the central part of the cornea, steeping the mid-periphery of the cornea. So they tend to have that bullseye pattern appearance, both of them. But the principles, you should understand GP lens fitting before you start diving into Ortho-K. For the training, an hour or two, it should be done.
All right. Thank
And you
you
have to
for
pass
that
an
question.
exam. I mean, once you go through the training, passing the exam is
All right. Thank you for the answer.